please give it a start.
Yeah, please go ahead.
All right. Hello, everyone. I'm Dr. Jasmine Marwaha, and I welcome you all to Global Interdisciplinary Summit, organized by Global Outreach Medical and Health Association and Global Summit. And now we are back with another renowned speaker, beautiful lady, and a dental diva. It gives me immense pleasure to introduce my favorite, Dr. Komal Majumdar. Talking about her, Dr. Komal Majumdar has graduated from the prestigious Government Dental College, Mumbai. She has completed her clinical mastership in oral implantology from State University of New York at Stony Brook School of Dental Medicine. She has completed her mini residency in implant prosthetics by Dr. Sachiv Raj and Kappa Dental, California. She is diplomate at the International Congress of Oral Implantologists and at the Indian Society of Oral Implantologists. She has completed her PG Cert in Endodontics from GDC Mumbai. She is in the editorial review board of Implant Dentistry, the official journal of ICOI, and also in the editorial review board of Spectrum Dental Teamwork magazine, Canada. She is the co-author of the book Clinical Fixed Prosthodontics and also Graftless Solution for the edentulous patients. She maintains a successful private practice in Navi Mumbai from past 16 years. So today she'll be talking about full arch reconstruction with tilted implants. And I'm sure this session will be profitable and everybody will enjoy and learn something new. So before moving ahead, I would like you guys to register yourself for CE at www.gomha.org. Thank you. Over to you, ma'am.
Thank you so much, Jasmine. That was a very sweet introduction. Thank you very much. And I'm really honored with such kind words. Thank you again. So hello, everyone, and welcome to the webinar of full arch reconstruction with tilted implants. Now, before I go ahead with the WhatsApp, with the Facebook Live, let me say a big thank you to Global Summit and Dr. Kianu Shah for inviting me, and a big thank you to all of you who are here watching me today. I hope that the next 1 hour that we have is constructive for all of you. Having said that, before I really begin, let me first show the final result of some of my tilted implant cases. If you look at this atrophic jaw, for example, if you see the upper jaw is quite atrophic, and here we have restored the case using tilted implant concept and finally with a acrylic hybrid prosthesis. Or this case where with a 5-year follow-up, in which you can see that the upper and lower arch both have been restoring the tilted implant color prosthesis has been given to the patient. Or in this case where again severe atrophy in both the upper and lower jaw has been successfully treated, again using a Malo PFM prosthesis. Or this case, for example, where we had to restore only the lower arch with denture implants with the tilted implant concept and restored again using the acrylic hybrid prosthesis. Or this case where we had to unilaterally do a case of zygoma and tilted implant concept at the same time. And or this case again with the tilted implant concept in the upper using biohorizon implants and the lower ones again, where we could give the patient a zirconia prosthesis. Or this patient again with the full arch reconstruction using the Tooth Express protocol by biohorizons, where we converted the patient's existing denture and could restore the patient immediately. Or this patient again with zygoma implants on either side, again restored with a hybrid prosthesis. Or this case again where you can see where we've gone for quad zygoma, that is again a tilted implant concept where we have placed 2 zygomatic implants on either sides and then given the patient a final restoration again with a zirconia prosthesis. So I showed you almost 9 or 10 tilted implants with different systems and with 5 to 7 year follow-up. And I personally feel that this is one of the most predictable and repeatable and a very practical approach for rehabilitating atrophic jaws. This, however, was not my philosophy for a long time, because I too believed in this quote, which was very famously said by Dr. Carl Misch: all on four or none on three. But I had the opportunity to change my opinion, because one of the reasons why people would not and we would not believe in this concept for a very long period of time, because there were not many studies, and a lot of people would just keep on insisting on going for axial implants. So as I said, that I had the chance to attend a meeting in Miami in some years back, where we had Dr. Craig Misch, who was Dr. Carl Misch's own brother, was talking about tilted implants, and he himself admitted that what his brother once had claimed is no longer relevant, because there are enough studies now to show that tilted implants work. Something like this, which says that there is almost 99% survival rate of tilted implants. Or this study, which says that even 4 implants are good enough to restore a arch. Having all these studies, it's all fine, but the real change in my whole attitude towards tilted implants really came in when I heard this great man, Dr. Paulo Malo, talk about the tilted implant concept. And a lot of people consider him as the pioneer in the tilted implant scenario. He had come to Mumbai a few years back, and I had the opportunity to hear him, and I could see the passion with which he spoke about the entire concept. Now, I don't really remember a lot of stuff about what he taught me or taught us on that particular day. What really stuck into my head was this building, his clinic, which is an 18-story building. And I was totally amazed at the entire concept, and I was charged and motivated, and I wanted to go ahead and do this particular concept, use this concept in my own practice. So I went ahead and I convinced my first tilted implant case. Excuse me. So meet Mr. Shirsar. He was my first tilted implant case. Here he wanted to go ahead for implants. I saw his clinically, he had heel ridges. We saw his OPG. And since I had heard Dr. Palomalo, I saw him doing the protocol. I saw that he was going guided, and I wanted to do just the way he worked. So I went ahead, made his dentures. We got the dual scanning done for a guided protocol. We got the stents made. Now, usually stents these days stents are made very, very quickly, but at that point of time, a few years back, it was not that easy. So these stents took a while, and in that period, my patient started losing his patience. He was getting quite uneasy. He wanted to do it as fast as possible. So I went ahead, I did my guided protocol for the lower and for the upper, and I went ahead and placed these implants. These are tilted implants, which were totally with the guided approach. However, at this point of time, I had committed the patient immediate teeth, because that is what the protocol is. You give the patient immediate teeth within the next day. However, since it was very new to me, I got confused. I had no idea how to proceed. So I just went ahead and told the patient, you know what, I can't give you teeth right now, with some reason I gave him. The patient went back. I gave the patient a denture. But these patients tend to get a little more impatient, because they have paid you loads of money. Plus, you have promised them that you want to give them teeth. So he came back within a few weeks and he told me, I want teeth as fast as possible. So when you're a young practitioner, you want to please your patients, you want to do everything that they want to do, and sometimes your common sense takes a back seat. So I went ahead and I started doing the prosthetic part. Of course, because it was still in the healing phase, the patient was in immense pain every time I used to do any prosthetic step, and really I was absolutely clueless as to why things are going wrong with me. And on the last day of my delivery of the prosthesis, just when I was going to deliver the prosthesis, I remember that day very clearly. I was supposed to give the prosthesis and go out. And, the moment I removed the healing collar to place the prosthesis, along with the healing collar came out my implant. Now, I was scared. I was worried. I had no idea what to do. So I just went ahead and put that implant back with the healing collar and told the patient, you know what, that's it for today. We'll see what has to be done. So I didn't know what to do. And, I have heard this amazing saying, if you don't know what to do, don't do anything. So I just went ahead and told the patient that it is not possible today. We'll go ahead and do it some other time. I needed the time to really think as to what I really need to do. Since after that, I had no clue, I called the patient and I told the patient, please take back all the advance that you have paid me. I'm sorry, I can't help you. Please look and for some other dentist who can help you. The patient took the money back. But in a matter of, I was relieved. To be very honest, I was relieved that the patient was gone. I didn't care about my losses. All I wanted that the patient doesn't come back. Unfortunately, after 2 days, he called that he's coming back. And he said that, I felt really bad that you gave the money back to me. To be honest, in my mind, I was thinking, so am I feeling extremely bad about the whole thing? However, he said that I don't care. I don't want to go to any other dentist. I want you to do my implants. This was a catch-22 situation. I was absolutely, in my head, I was going, oh shit, I don't know what to do. So I realized that, this tilted concept really doesn't work. This is all marketing gimmick. I don't believe in this tilted implant concept. I will go with axial. So I just went ahead and placed a few more axial implants. I told the patient, you know what, we can't load it immediately. You really need to wait. The patient waited. And then, of course, we went ahead and eventually, loaded these prostheses, giving this kind of smile to the patient. But of course, and this is the immediate OPG of the patient. And the patient did not pay me back till the last day because he was not sure whether this will work or not. In fact, he had the audacity to tell me, I want to take these teeth back. I'm going to go home, eat, and then decide whether I need to pay you back. Now, at that point of time, there was a bell in my head that said, no, this doesn't work like this. So believe it or not, I gave this patient something to eat in my clinic so that he is satisfied and he could pay me back. So my first experience really with tilted implants was not so smooth. And of course, this is the immediate OPG. And if you look at the patient, it's an 8-year follow-up. The patient was happy. Things are fine. This was a picture of him and me taken after a period of 8 years. So if you can understand what exactly were my feelings on tilted implants after my first case, as I said, that I was totally a non-believer at this point of time. I knew in my head that this tilted implant concept really doesn't work. It is a marketing gimmick, and I am never, ever going to do tilted implants in my life. However, when I look back at this case, I realized that most of the mistakes that were done were by me. It was not the system. It was not the concept. There were glaring mistakes that were done in each and every step, and things that could have been avoided in every step there. So keeping this case as a background, I'm going to talk about the topic for today, and that is the fundamentals in tilted implants and with full arch reconstruction with tilted implants. So how are we going to go about it? We're going to go about it in two parts. In the first part, I talk about the conventional tilted implant protocol. And the second part, I talk very briefly about the zygomatic implant protocol, because zygomatic implants also are a way to rehabilitate very atrophic jaws. And it is, after all, a tilted implant concept. So how are we going to go in the first part? In the first part, I talk about the treatment planning. We talk about the components, the surgical phase, temporization, final prosthesis, and failures, because any discussion without failures is incomplete. In the second part, I talk about the zygomatic implant protocol, where I talk about when do you have to go for zygoma. We talk very briefly about the classification of doing the zygomatic implant protocol, and of course followed by cases, some take-home points, and that's how we will conclude. So this is going to be roughly an hour, 1 hour, 15 minutes presentation, and I hope that the net is okay at that point of time and we do not lose our connectivity. A lot of people are losing their connectivity these days. In case it happens, we will be back in 5 minutes, hopefully. So be patient if that happens, and join us back in case we have some network issues. So having said that, let's start with the presentation, the full arch reconstruction with tilted implants. So what are tilted implants? Tilted implants basically are your regular implants which are not placed straight, but as the name suggests, are placed at an angle. They are placed anterior in the maxilla to the anterior wall of the maxillary sinus and in the lower anterior to the inferior alveolar nerves loop. Now, basically, this is done to avoid any kind of uh, extensive surgeries. We are utilizing the more dense maxillary and mandibular anterior bone. By tilting the implant, what we are essentially doing is we are reducing the amount of cantilevers that we can give to our patients. So this concept of tilted implant should be done. But the question is, why do you want to go for tilted implants? The first and the most important reason is that it is acceptable to the patients. Any patient would jump at the prospect of getting the teeth the next day or within first 3 days. The patient has to not undergo any kind of major surgeries. The patient gets teeth immediately. All of these procedures that are done with tilted implants are at the level of abutment. So here, the patient doesn't have to go for a second stage surgery, and there are no cantilevers, as I already mentioned. And all of this basically saves your time, your patient's time. And we know that as a dentist, for us, the biggest uh, factor in our practice is time. More the time, more we can see, the more the number of patients we can actually go ahead and see. So coming to the treatment planning, the first is case selection. Which cases really are indicated for tilted implants? Now, for any full arch case, the golden rule should be remembered. And the rule is tilted implants have to be considered as an option only when straight implants are not an option. That means if you have adequate bone present, do not go for tilted implants. These are restricted for certain cases. And to really understand this, we have a beautiful classification for us to understand in the maxilla, which is called as a Bedrosian classification, in which the maxilla is divided into 4 zones. Zone 1, 2, 3, 4, from canine to canine, premolar, molar, and zygomatic, respectively. So in this classification, if you have got adequate bone present in all the zones, 1, 2, 3, go ahead, place straight implants, no need to go for any tilted implants. Bone present only in zone 1 and 2, go ahead, place your regular conventional tilted implants. And if you have bone only in zone 1 and 4 or only zone 4, you either go with single zygomatic implant or quad zygoma respectively. Now, when we talk about tilted implant, the first thing that comes in our head on it, or it is synonymous, is all on 4. We understand that when we talk about tilted implants, the concept of all on 4 or restoring the entire arch with 4 implants comes to our mind. But the question should be, when we are agreeing or disagreeing about the number of implants, how many implants are really required per arch to optimally restore the arch or the case? So is it 1? Is it 2? Is it 3? Is it 4? Is it 5? Is it 6? Is it 1 implant per tooth? Or is it 1 implant per root? Now, that depends. Now, there is this one beautiful study that was done by Dr. Brunsky, in which he understood really the forces. So that is the deciding factor on how many implants really are required. So he did this study, and what he found was that it is not the number of implants that make the difference. The main concept, the main idea is to have a good AP spread. And when we calculate the forces on the implant, by tilting the implants, what we are essentially doing, like if you can see here, we are decreasing the length of cantilever. And by tilting the implant, what we are essentially doing is we are increasing the AP spread. And the forces on the implant is not calculated where the implant enters the bone, the blue arrow that you can see in the picture, but it is calculated in that area where the implant joins the prosthesis. That is the point where you can see the circle. That is the point. So you can see at this point, the AP spread by tilting the implant increases. And the main deciding factor whether the forces are going to be same as conventionally axial implants or tilted is going to be this AP spread. So the tilting in the implant essentially is increasing the AP spread and decreasing the length of the cantilever. And of course, there are other studies to show that inclination of the implant does not affect the marginal bone loss, and the stresses compared to, if you compare straight and axial, remain the same even if you're tilting the implants. Now, again, one of the questions that will come into our heads is, isn't tilting a problem? Aren't we taught that straight implants are always better? They deliver compressive loads on the implants, and tilted implants will always give shear loads. The answer is yes. If you consider a single tilted implant and if you compare one straight implant, the forces, of course, are going to be higher on that one single tilted implant. But if these tilted implants are joined cross-arched rigidly together, the forces are distributed evenly. And this is the study that shows that. These are the studies that show that there are two factors that you have to consider in tilted implant. One is rigidly joining all of them together, and second is the AP spread. How big or good a AP spread you can give. Bigger the AP spread, lesser are the forces. Of course, the number of the implants will also depend on the opposing arch, the age, other factors. So do not just get so involved in the number. Look at the overall picture. Look at not the arch but the entire patient, and then decide whether that would be a correct protocol for that patient or not. A 35-year-old edentulous patient is completely different from a 75-year-old, and then your treatment planning should be dependent on a lot of other factors. So let me show you one case which was very easily rehabilitated with a tilted implant concept. So meet my patient here. She's a 65-year-old lady. She has got no relevant history, but she's got severe atrophy in the posterior. She has been missing these teeth for a long time, and along with the teeth, even the alveolus has extruded a bit. So we go ahead. So this is what the initial picture is. This is how it looks like. You can see the amount of wear in that teeth. So we go ahead, we remove all the teeth, we create a base. Now that is very important because the alveolus has extruded out. We need to create a proper occlusal plane, and for this we need to remove the bone that has come up with it. We create a plane, we go ahead, do our osteotomy, we place the implants anterior to the anterior loop of the inferior alveolar nerve. These implants are placed, we place our multi-unit abutments, the prosthetic components over it, and the next day the patient gets a fixed prosthesis. This is a temporary prosthesis. This is how the patient walks away from the clinic after the delivery of the prosthesis. She comes back after 3 months. We go ahead, make our impressions, jaw relations, teeth setting trial, and that's the final prosthesis. So here in this case, we have given these transverse screws, which are working fine, and that's the final case, final prosthetic part that we have done, the upper one, which is restored also, and that's the final smile of the patient. Now, coming to the other part of treatment planning, and that is the loading protocol. When do we go ahead and load? That is something which we need to understand. So when you talk about tilted implant concept, the idea is to load the implants immediately. And we can have several failures if you do not understand the science behind immediate loading. And that is where I exactly went wrong with my first case of tilted implants, Mr. Shirsad. So the golden rule again in immediate loading is either load the implant immediately or load it after a period of 6 weeks. Now, why am I telling you this? What is the science behind this? So for this, you need to understand how immediate loading concept works. So if you look at the black arrow on the left-hand side of your screen with the number 100 there, that is your primary stability. That is the stability, that is the torque that you have achieved on the day of surgery. Your implant is rigid, but please, and that is your primary stability. And the red arrow on the left hand side of your screen where 0 is written is your secondary stability or the process of osseointegration, which is 0 on the day where you give the patient the prosthesis. And as you see, the primary stability does not remain the same. It keeps going down, and by the end of 6 weeks, it is absolutely 0. The secondary stability, on the other hand, keeps on increasing. However, it takes almost 6 weeks for it to really start showing, or the implant gets integrated. Now, the reason why I'm showing you this, not the part which is important to us. The part which is important to us is the area which I have shown you in between this purple patch, the blue arrow. That is the point where your primary and secondary stability is at the lowest. So if you want to load these implants in the beginning, where the primary stability is high, where you are placing the implants or subjecting the implants to physiological loads, or load it once the implants are completely osseointegrated. And that is exactly where I went wrong. Now, having a high primary stability and joining them together reduces the micro movements. Micro movements basically are the movements of the implant when the implant is healing. And for us, we have to remember that it has to be kept below 150 microns. Now, why is this very critical for us, and how will we convey this to our patient? I will tell you in a bit, because we can't possibly tell the patient, make sure that the forces are below 150 microns. There has to be a certain way to make them understand this, and we'll come to it in a bit. So again, of course, when the patient is given immediate loading, what about the forces? The implant is going to be subjected to a lot of forces. There are three forces basically that are acting on the implant: along the long axis, mesodistally, and buccolingually. And the only way to reduce all these loads is to rigidly join all these implants together. It is very, very essential that your splinting, that your joining of the implants with your temporary prosthesis is rigid, because if it fractures and if the patient is not aware of it, it will lead to micro movements and obviously the loss of implant in the long run. So let me again show you another case. 68-year-old male patient who walks in, who wants something to be done for his upper jaw. So we can see that the teeth are completely non-restorable. We go ahead. This is the initial situation. We extract the teeth. We do the degranulation, a very, very important step when you are doing any full arch case, be it straight or tilted. We place the implants here, in this case, 2 tilted and 2 straight. We place the necessary prosthetic components. I'm going to talk about this in a bit. We make an impression. We make a temporary, immediately we fabricate it from the lab. We pick it up and we ensure that it is passive. The passivity is maintained, one screw test done. This is the temporary. You can appreciate the AP spread that we have got. This is what is the most important factor when you are dealing with tilted implants. So that's your patient in maximum intercuspation. This is the pre-op OPG, and that's the immediate temporary immediate post-op, lowers with axial, upper with tilted. This is a very, very common and routine procedure that you can that is going to be done in your practice once you incorporate this this concept. So here we go ahead, and this is the happy patient that we have. Now, show one more case to you. In this case, now, although tilted implant is considered as a immediate loading protocol, but there will be times in the beginning, probably when you're not very experienced with the whole thing, or possibly where you possibly you do not get the initial stability. Maybe the patient is diabetic and you do not want to load these implants immediately. So in that case, you can also go for a delayed protocol. I avoid doing that, but in case we have to, this is what I do. So this is one of case. Meet my patient Kamal, a very sweet lady who wants teeth, and unlike a lot of other patients, she's a very patient. She has got a lot of patience, and she wanted to go ahead and place the implant, but she was mildly diabetic and I did not want to load it immediately. So in this case, I went ahead and I planned upper tilted implant and lower axial implants, but I kept them submerged, and I came back after a few months. In this case, now in such cases, if you have to give the patient a denture. Now I hate giving a denture to my patient. If you have to give a denture to the patient, make sure that you reline them with a soft liner. I like this patient a lot because she was one of those patients who said, you know what, I don't care. I can be without a denture for a few months also. So one of my favorite patients, because she is ready to listen to me, and she knows that when I'm telling her that there should not be a denture, because even if you have a denture, which is relined, there are still forces that go on these implants. So you need to ensure that you give right instructions to your patient. So we go ahead now. The patient was, these are the multi-unit abutments given, and the impressions were taken. We did the jaw relation. We went ahead and did the teeth setting trial. There's the final prosthetic phase. We give the patient an acrylic hybrid prosthesis. The upper and the lower one was also a hybrid prosthesis. This is a maximum intercuspation. And that's the final picture of the patient. So here we can see that although we went with the all-on-4 concept, we did not go for immediate loading at all in this case. Now, one more aspect of treatment planning is whether you want to go for tilted, or whether you want to go for guided, or you want to go for a freehand approach. Now, I am a big fan of freehand approach. However, guided should be done. Now, you saw that I did guided approach in my first case. However, I do not like a guide which is tissue supported. I like a guide which is more or less a bone supported guide because that is much more stable. So although we don't have too much time to discuss about the entire thing, I'm going to show you a case as to how you can proceed doing a guided approach with your tilted implants. So here we can see that this is the patient. She's a young patient and she wanted something to be done for her to eat for her rehabilitation. So she walks in, this is the lower arch, and you can see the amount of you know the resorption that has happened. She's got a very thin ridge. Crestotomy is required here. We go ahead, we scan the patient, we scan the denture, and we create a stereolithographic model. We also make a temporary beforehand. We go ahead, make an incision and expose the mental foramen, expose the bone, because and a lot of flap elevation is required in such cases, primarily because we need to place the stent very, very properly. So this is the bone reducer guide. We go ahead, we place the first guide. This is going to tell us how much of bone needs to be reduced. We stabilize it with anchor pins. We take a piezo. I'm not going to throw away that bone. I'm going to use this alveolar bone that I'm going to remove. I'm going to use it in the subsequent slides. You'll go ahead and see it. I create a base. Now I place my second guide over this. And now I know where and how much angulation is required. So I'm just going to use my handles, do my osteotomy, create a ramp, and place my implants in the position that I want. I go ahead and make my impression. I'm going to immediately load these implants. I've got very high primary stability. Make my impression. And in this case, I go ahead and use these plates as a Khuri plate, do my contour augmentation along with it, and then close. There's my healing caps are placed. We go ahead and give the patient a temporary. The cylinders are integrated. That's the temporary that we have. And that's in maximum intercuspation, the final smile. So you can see that, you can do it in flapless, you can do guided, it's up to you. Now, the next part of my protocol is the components. Now, one of the reasons I could not proceed with Mr. Shirsad once I placed the implants, because I really got confused with the components. Now, there are not many components in tilted implants, but there are a few. Once you understand them, things are easy. But the initial part where you need to understand what is what, tiny little, tiny little components, which can be a little confusing. So let's talk about it. So there are very few, as I said. The first is a guide. Now, you have to understand that your implant needs to be placed at an angle of not more than 45 degrees in your regular tilted implants, because the components over it, the prosthetic components over it, can only compensate to that limit. So you need an angulation guide, which will show you that you are going up to 45 degrees. So this is readily available in the market. The game changer really in your tilted implant protocol are your abutments. These are the components that really are the ones that will help you get the angulation correct. So when we talk about an all-on-4 concept, you have to understand that we are talking about a screw-retained prosthesis. And these multi-unit abutments basically convert your internal hex to your external hex. And these multi-unit abutments can be either straight or it can be angled. So right from 0 degree to 17, 17 and a half, 30, 35, 45, 52, and 60, depending on which system you can go for. Now, in your regular conventional, you don't require more than 35 degree of tilted of multi-unit abutments. When you talk about your angled multi-unit abutments, there are two screws that are involved. One screw is the one on the side which engages the implant. And once it engages the implant, this multi-unit abutment does not have to be removed. There is a handle on the top which will help you guide the placement of this multi-unit abutment. And this is the point where your prosthesis is going to be connected. Your straight multi-unit abutments are usually, they are given with a handle and they have to be torque wrenched with a 4 mm hex driver after you place them. So this is how it looks like. So if you look in the front two with the handles, these are your straight multi-unit abutments. On the posterior, these are your angulated multi-unit abutments. Typically, you require 30 degree multi-unit abutments for your posterior implants, 0 degree multi-unit abutments usually for your mandibular anterior, and most of the times a 17 degree or a 17.5 degree multi-unit abutments for your upper anteriors because of the angulation of the bone. And this makes sure that your access holes are coming palatal. And in the posterior, they're coming occlusal. You, of course, require open to impression or a close to impression coping for the multi-unit abutment. Everything is happening at the level of the abutments. You are never, ever going to go back to the implant. So this really follows the one abutment, one time concept. You, of course, you require analogs You require healing caps. By the time the patient goes back and comes for the immediate restoration, you do not want the tissues to bundle up. So these are the healing caps that go over the multi-unit abutments. You require titanium cylinders. Now, these are basically temporary copings that are placed on the multi-unit abutment, and your temporary is fabricated around these titanium cylinders. And finally, a small prosthetic screw. These are 0.9 mm screws, very tiny screws, and you'll be surprised that these are the screws that really are holding your entire prosthesis. This is a perfect example of great things come in small packages. These are very tiny screws. They usually have to be tightened from 10 to 18 Newton centimeter. Now that depends from one manufacturer to another. So that's about it. These are the only components that you need to understand when you're talking about tilted implant concept. Coming to the surgical phase. Now in the surgical phase, I'm going to talk about 5 things. Just there are 5 points to remember in the surgical phase. First is creating a shelf, a all-on-4 shelf. You ensure that you create a base for you to go ahead and place the implants at one single level. Why are we doing this? Because we do not want our implants to be at our prosthesis to go at a different level. It becomes easier for the patient to maintain. It becomes easier for the technician to fabricate the prosthesis, and you ensure that the prosthesis is even. That means you need to ensure that your crestotomy, your shelf, is made even in the front and at the back. And one of the ways to really understand, and the most important, is to create that prosthetic space. Now we will talk about it, and we will understand that every kind of prosthesis requires different space. Before the surgery, you need to decide whether you want to go for an acrylic hybrid, whether you want to go for PFM, you want to go for malo, you want to go for zirconia. All of these have to be decided beforehand, and each and every one of these prostheses requires different space. So ensure that space is created. You can cut these dentures which you have fabricated and see how much of space you have. So we'll come to this in a bit. The second point is ensuring high primary stability. Tilted implant concept means usually giving the patient teeth immediately. So by using any of these methods of expanders, under preparing, and more recently the denser burrs, you ensure that you get high primary stability of almost greater than 30 Newton centimeters on an average, so that you can go ahead and load these implants. Third is the ramp preparation. Now this basically is creating a saucer on the distal aspect of the last implant, so that once you place your multi-unit abutments, they do not get locked. So once you remove that bone at the end, you can go ahead and place these multi-unit abutments. I would suggest that you make the ramp before you place the implant, because once you place the implant, there's a risk always of damaging the threads. So ensure that you do it beforehand. And of course, when you're trimming, you need to trim out the excess gingiva. Again, another aspect, you do not want everything to be bundled up on the multi-unit abutments. And finally, please understand that tilted implants really does not mean that you have to have two straight and two tilted. You can have different angulations on your implant. It really doesn't make any difference. What really, really is important is joining all these implants together and getting a rigid splinting in these. Coming to the temporization. Now, when you talk about temporization for your tilted implants, there are 2 ways that you can temporize the patient. Either you make an impression, send it to the lab, and let the lab fabricate for you, the lazy way, the way that I like. Or if you are very efficient, very good with acrylic, you can go ahead and take the denture and convert it. So we'll talk about both of these, and I'll show you how to really go ahead with that. So lab fabricated, let me show you a case in which we'll explain to you. So there's a patient walks in who wants some teeth. He has got mobility. He's got severe case of terminal dentition, and we know that we need to remove these teeth. This is the initial situation. Despite this, despite the fact that that I know that I'm going to remove the teeth, I go ahead, do the prophylaxis. Very, very important step for you in the surgical phase to reduce the inflammation, reduce the bleeding, make life simpler for you. So that's the upper, non-restorable dentition. That's the lower. We go ahead, extract the lower, we degranulate. The lower are a regular, simple, straight axial implant placements. Create the shelf, place all the implants, and make the temporary for the patient. I'm talking more of the upper. I go ahead and extract all the upper teeth, go ahead and do my degranulation, do my osteotomy, the posterior implants anterior to the anterior wall of the sinus. Once all the implants are placed, I place my multi-unit abutments and I make my impression. You can place a rubber dam sheet, or you can place a sterile glove so that the surgical site is not contaminated. And then this comes to you. Now, in this case, one of the titanium cylinder that I was talking about is integrated by the lab. You pick up the other ones primarily because you want this prosthesis to be passive. So here in this case, we have picked up, we have polished, ensure that the seating is absolutely passive. And this, you can see that the temporary has been made by lab, one screw test to ensure passivity, seal the access holes, and that's how the patient walks in. Of course, this is how the patient goes. Patient comes back after a few months. We fabricate the final prosthesis. This is an MIP, the left lateral. This is the post-op, the final post-op of the same patient that we had seen in the beginning, and before and after. So we can see that this is very, very predictable, very, very easy. If you have committed the patient that I'm going to give you the teeth the same day, the patient is not ready to wait for a single day, you are in consulting practice, you can't possibly go again and again and do your consulting practice there. Patient is high demanding, and you're good with acrylic and you're good with working with this material, go ahead and convert the denture. So here I'm going to show you one case of Teeth Express protocol where this patient walks in. She has got, this is how the intraoral picture is. Now, this was a case where I had to consult somewhere, so I had no other choice but to convert her denture. So this is how she walked in. And unfortunately, I didn't have a CBCT for this patient. This was done in a setup of a city which did not have CBCT, so we had to make do with whatever we had. So this is the occlusal view, a thin ridge as expected in such cases. I go ahead and do my crystotomy, create a plane, do my osteotomy with densa burst. Understand immediate loading, high primary stability. You're looking at ensuring that you do everything possible so that your implants are absolutely stable. Create a ramp. Do not forget something that has to be done before the implant placement. Here I place my BioHorizon implants here. That's my final placement. And now in this case, these are 30-degree multi-unit abutments. I place them. I place my sutures and I place my healing collars. And now I take my denture, make an index out of it, identify the position of the multi-unit abutments, drill holes through the denture. And now you can see these holes are made. I place my titanium cylinders and ensure that the denture is completely seated and there is no hindrance at all. I place my rubber dam sheet, in this case a sterile glove, and then I pick this up using my Protem 4. Not a big fan of this material because it can be weak. You can use acrylic, you can use Q resin, you can use cold cure, you can use Protem. It's your choice, whatever you want. Once it is done, cut out all the flanges, cut out the palate. Do not make it too thin. You do not want this to flex, otherwise it will cause micro movements. Polish it, and that's your denture which is converted. Immediately make sure that you have a convex surface, not a concave, because if it is concave, there'll be food getting stuck. The patient cannot maintain the hygiene. Check for the one screw test. That's how we start off. That's how we finish. And this is where we started. And that's how we ended the case. Now, one study that talks that I want to mention here during temporization is that it is seen that the maximum amount of failures, almost 74% of the failures, occur in the first year of placement of tilted implants. What does this signify? This signifies that if you can extend the phase of temporization for a bit longer to evaluate the case, it would be great. This also implies that give the patient high strength acrylic. If you're going ahead, go ahead, do intraoral welding if you have a welder with you. I do not do it. However, that is one of the very good efficient ways to ensure that the temporary doesn't break and you have rigid stabilization. One of the reasons I do not like to convert my denture is because you can make it significantly weak. If you can see here how much weak the denture is. So this is a risk factor. So this is something that you need to keep in mind when you're talking about temporization. So the most important aspect of this is to give the patient correct instructions. Remember, I told you not to make the micro movements greater than 150 microns. One of the most effective way of conveying that to the patient is to tell the patient to be on extremely soft diet. And here, when I say soft diet, be very, very specific. Tell them what they are supposed to eat and what they are not supposed to eat, depending on where you stay. If you're staying in a place where people love to eat steak, tell them not to eat steak. You might convey telling that's normal, eat normal food. Normal food for them might be steak, might be apple. You have to be very, very specific. Eat pasta, eat boiled egg, eat khichdi in Indian scenario. You have to be very, very specific about that. Inform the patient that in case he feels that if the temporary is fractured, even if he dreams about it, come and visit you so that you can take care of it immediately, because if it fractures, there are micro movements leading to failure of the implant. So very, very important. Another very important aspect is to ensure that oral hygiene instructions are given to the patient. These patients are not used to brushing. Ensure they have reached this stage because they were not brushing. So ensure that you give them proper hygiene instructions at this point of time. Do not wait till the final prosthetic stage starts. Now, coming to the final prosthesis, how to choose the final prosthesis? First of all, it has to be decided not after the surgery, but has to be decided before the surgery during the treatment planning phase. And it has to be decided by you, not by a technician who will say that I can possibly, with this space, I can only do this kind of prosthesis. So you need to be planning beforehand what you want. So what are the guidelines? So one of the factors, of course, there are other factors of the patient expectations, the economics, all of these aside, one of the very important aspect is how much of space do you have. So if you have space for one arch from the occlusal plane to the head of the implant up to 10 to 12 this is typically a case of FP1 prosthesis where you have only white. If there's space of 12 to 15, this is a case typically of a FP3 prosthesis where you have porcelain with pink. If you have a greater space, 15 to 18 millimeter. Now, usually when these patients come to you for tilted implants, you will see severe atrophy, and this is the kind of space that you're going to see. So either you go with an acrylic hybrid prosthesis. If the patient is aesthetically demanding, you want to go for porcelain, go for a malo prosthesis, go with a bio HPP prosthesis. So these are the multiple choices that you have when you're deciding. So let me show you one such case again for atrophic jaw where I've used bio HPP as a material. So this patient is a relatively young patient. He has he has a terminal dentition. He's scared of the dentist and he has reached to a point where he really nothing much can be done about it. So you can see there is a lot of sinus pneumatization. His incisal edge position is changed. We go ahead and we remove the teeth and we place a little more implants, if you can see, considering the age of the patient. I do not remove the last teeth to maintain the vertical. Things become relatively easy here. I give the patient temporary for the lower, for the upper, the same day or maybe the next day max. Patient comes back after 6 months. You can see the healing. I go ahead with my impressions, make my impressions, do my verification jig to ensure that my impression is correct, do my PMMA trial again because I'm going for a mild prosthesis. I cannot afford to have any kind of discrepancies. And here I have a bio-HPP framework with Crealine in the pink part. Again, for the lower, this is the occlusal and palatal holes in the lower. And this is in maximum intercuspation. Check the occlusion, in protrusion, in excursions. Give the patient hygiene instructions, again important. And this is the post-op OPG of the patient. So this is what the final looks of the patient is. And that's how we had started. And that's how we are completing this case. So you can see that this patient had immediate teeth, young patient. Psychologically, he is not feeling old because he walks in with the teeth, he walks out with the teeth. This is something of a game changer for your patients. The number of patients who are going to agree to do these kind of modality of treatment is amazing. Once we go back after this COVID situation, go ahead and get excited about this entire protocol and incorporate that in your practice. Of course, as I said, that no discussion can be complete without management of complications. I'm going to discuss one complication. And typically, your complications happen in cases where you don't want them to happen. Some high profile case, some VIP patient, some patient who is known to you, some patient who's very demanding and is very fearful that something might go wrong. And these are typically the patients where something will go wrong. So let me show you one case where I had a failure, but we can take care of it. So let's understand this. This is a patient who is walking in and he has, of course, requires tilted implant protocol. That's the maxillary. That's the lower arch. We go ahead, remove the teeth. We have knife edge ridges. I somehow place 4 implants, very, very poor ridge, manage high stability, place my multi-unit abutments, make my impression, and give the patient a screw retained prosthesis. Everything was perfect. The only thing that went wrong was this patient was not given instructions thoroughly. The patient took, I feel that was my, from my side, things went wrong because I was not insistent about the eating habits. So the patient went like this, and the patient came back after a few months. When I wanted to make the impression, I realized that the implant that they have placed on one side is moving, and trust me, if it is moving, it is not going to go back to its original position, or it's not going to integrate by itself. So I went ahead, I removed the implant, and at the same time, I did my degranulation. You can see here, thankfully. Now, one of the very important aspect is if you identify a failure, act on it immediately. Do not wait that it will automatically integrate. Do not hope for miracles when you're talking about implantology. If it has failed, it has failed. It has failed to integrate. Go ahead and now restore, remove that implant, because the longer you wait, the more loss of bone you're going to see. So in this case, there is thankfully no buccal bone loss. I removed the implant, I did my degranulation, and after the degranulation, I again placed another implant. And because I was so fearful that something might go wrong, now that is one of the biggest problems of tilt, biggest problem with placing 4 implants. Now, although we have a study to show that 4 implants is enough, I still go ahead and over engineer, primarily because if one fails, I still have another implant where I can give the patient an immediate temporary. So in this case, I placed the 5th implant as a, making sure that things go fine at a later stage. I'm a little scared now. So I do my indirect sinus lift, I place that implant, I submerge it, and I give the patient another set of temporary for a few months. The patient comes back. Now I've loaded all the 5 implants, place multi-node abutments, make my impression, do my PMMA trial. I'm going to go for a mild prosthesis here, which is bio-HPP. That's my final prosthesis here. You can see these are very light prosthesis. I do my 1 screw test, a very important aspect, again, making sure that your prosthesis is passive. And that's the final case, lower axial, upper tilted. Most of my cases are upper tilted and lower axial, and it works. And in this case, you can see one is straight and there, and it's all right. There's no rule that the most distal implant has to be tilted. You can really work your way through. Every case differs. So that's in maximum intercuspation. And finally, more than the patient, happy me, because everything worked out fine. Now coming to the next part of the discussion, and that is the zygomatic implant protocol. Now, let's coming to zygomatic implant protocol. The first part that I want to talk about is when do you go for zygoma implants. So if you remember the classification that I spoke about, the Bedrosian classification, again the same concept here. If you see that bone is present only in zone 1 and zone 4, that is the time where you want to go for zygomatic 1 straight and zygomatic implant. And if you have bone placed only in zone 4, like on the left hand side of your screen, that is the time where you want to go for quad zygoma. And there are times where one side you'll have bone, the other side you won't. So you can place one side zygoma, one side tilted. Again, depends from case to case. Remember the golden rule: go for tilted only when you can't place straight implants. Go for zygoma when everything else has been exhausted. What about the pre-prosthetic surgical planning? Now, coming to zygoma, we really there are 3 techniques that are in zygomatic implants. One is the original Brennemark technique, then was a slot technique, and a more recent Zaga approach. Zaga stands for zygomatic anatomy guided approach. So let's start with the original Brennemark protocol. Now, in the original Brennemark protocol, to be very honest, even when before the conventional implant protocol started, it was the zygomatic implant which was introduced by Dr. Brennemark was much before the conventional, because these were the implants that were used to rehabilitate patients with cancer, or with absolutely the dentures not being there, not getting seated because of the severe atrophy. Now, in this, regular longer implants were placed. Now, the whole agenda of this placement of this was to engage the zygomatic implant, but also making sure that these polished implants go through the sinus and engage the zygomatic bone. Now, to ensure that these implants are going and engaging the zygoma, a slot, a small little window was created as close to the zygomatic bone as possible, so that the path of insertion of the zygomatic bone, of the zygomatic implant, could be visualized. Now, of course, this was a boon. This was, for some of the patients, it was amazing. They had teeth. However, there were certain problems associated using this protocol. First of all, because it was going through the palate, the prosthesis became very, very bulky. It became very difficult for the patients to clean this. Hygiene maintenance was an issue. Speech issues were there because it was encroaching the palate, and because these implants were surrounded not by attached gingiva but around the palatal tissue, which is weaker and cannot resist any kind of infection. So the patient had higher chances of mucositis. Plus, the amount of buccal cantilevers placed in the palate, the amount of buccal cantilevers that were there were a little more. So here, there were certain modifications. One was a slot technique that was introduced by Stella, in which again a slot was created to visualize in the buttress. The more popular one now is the Zaga approach, that is the zygoma anatomy guided approach, wherein the direction, the placement of the zygomatic implant is not necessarily going through the sinus. What really decides the direction, the placement of this implant is the lateral wall of the maxillary sinus. So your implant does not, the crest, the platform of the implant is not on the palate, but it is as close to the crest as possible. There is no slot, there is no window that is created. There's a channel that is created from the first point that is on the crest towards the zygomatic implant. And depending on the anatomy, there are 5 approaches, right from type 0 to type 4, which and this classification really is which or where exactly is your implant. So if your lateral wall of the maxilla is straight, at this point of time, the implant is placed on the head of the crest, alveolar crest, and the implant goes right inside or through the sinus. So this is Zyga type 0. If you have slightly concave lateral wall, in this case, you have a intra-extra approach. That means most of your implant is intra-sinus and some of it is in extra. The implant's head is on the crest of the bone. You can have an extra intra. That means it is slightly more concave. In that case, most of your implant is out. Some of the implant is inside the sinus. You're getting engagement in the zygomatic bone and the platform of the implant is at the crest. You can have an extra sinus. Now, in this case, when there is severe atrophy, rather than the implant's head being engaged in the crest, it is outside. It is buccal to the crest, and it is engaging the zygoma. And then you have your extra maxillary again when it is extremely concave. So now it will depend from patient to patient. One patient itself, a single patient will have 2 different approaches. Maybe one side Zaga 0, maybe one side Zaga 2. That depends from patient to patient. So the best way to really evaluate that is your CBCT. And again, another way to evaluate that is to make these kind of stereolithographic models in which you can really appreciate the anatomy. You can understand where should be the tentative intraoral entry point, where should be the extraoral point on the zygoma. You can do a mock surgery. It always helps to do a mock surgery. This surgery is a little difficult. A lot of people do under general anesthesia, but a lot of people do under local anesthesia. So doing a mock surgery, understanding where the intraoral point is, understanding where your implant is going to enter, the point of entering the zygoma can be calculated, and where the exit is. Create a channel first with this kind of diamond drill. This is from Norris. So a channel is created. Once this channel is created, you take your extra long drills. Now these drills are a little difficult to, literally, we are not used to these long drills. So the first time probably when you're doing this, you are going to be anxious. I am anxious every time I hold this drill in my hand. It is a longer drill, so you don't have the kind of control that you have with your regular implant drills. You go ahead and direct this and find out an extraoral exit point. Now, when you're doing this extraoral exit point, unlike in implants, regular implants, where we have decided the diameter, the length beforehand, here we have to decide the length of the implant. During the surgery, you need to feel it extraorally here when the probe, the depth probe emerges out, and you can feel it on your skin here. So that's a little extrusion, not too much, because it will unnecessarily lead to patient having problems here, draining sinus there. So you do not want that. So let me show you a few cases of my zygomatic implants here. One is a case of severe atrophy, a young patient, but she has been wearing denture for a very, very long period of time. And you can see that she's got severe atrophy, no bone. The only bone that we can really engage is the zygomatic bone. So of course, I do my study. I understand how the sinus is. Having a healthy sinus is essential while you're doing this kind of surgeries. You see the smile line. First step, whether it is tilted implant, axial implant, zygoma implants, fabricated denture, evaluate the space, make a stereolithographic model in this case, and I plan my surgery where my anterior implants are, where my posterior implants are. Again, a very important aspect here would be to get a good AP spread. The principle remains the same. So I go ahead, I do my mock surgery outside. outside in the patient's face too, I kind of mark where my tentative points of exit are supposed to be. Again, when you're doing your cord zygoma, you have to be ensuring that you do not damage the orbit. So that's my intraoral picture. Start one side, it's a extensive surgery. Do not open up the entire flap. Raise a little higher flap, expose the zygoma, mark the points, mark your direction tentatively. This approach of zygomatic implants can also be done guided, and hopefully in the future I can share a case where I have done a zygomatic implant with a guided approach. Things become relatively easier. Then you make an intraoral point, you make a notch where your implant is going to enter the zygomatic bone. Now you go ahead and make a channel. You ensure that this is not going inside the orbit. Once the channel is created, you can lift up the membrane. Now the implant that I'm going to use is going to have a smooth surface on the top. So even if it's contacting the Schneiderian membrane, it is not really going to be a big problem. I go ahead and do my osteotomy, place my implant, and you get very high stability with these kind of implants. So you place your implants. These are my 2 implants placed. All the 4 implants placed. We have made sure that we're not inside the eye. This is for soft tissue healing. I take my PRF, place it on the smooth surface, close it, and now this becomes like your regular tilted implant case, where I place my healing collar. Of course, the multi-node abutments that I use here would be slightly more angled than my other regular implant cases. A lot of clinicians, along with these zygomatic implants, also go for pterygoids to get more AP spread, to get more teeth. So it's up to you. If you know how to go ahead with your pterygoid implants, go ahead. If not, just even this protocol is fine. I pick up just like we spoke about in a few minutes ago. And then of course I'm going to make this concave surface to convex. This is the part which I find extremely boring and extremely time consuming. So once that is done, I check my passivity once to test. There's a patient how she walks out. That's how we had started off. That's the 4 zygomatic implants placed, and this is the post-op of the patient the next day. Such patients, if they are medically fit, give the patients an injectable steroid so there is less swelling, inflammation, and you can deliver the prosthesis faster. That's the coronal section. She patient comes back after 6 months. Everything is healing fine. And I make a titanium framework with individual zirconia crowns, beautiful aesthetics and function. And that's the final OPG, lower tilted, upper zygomatic approach. And one of the difficult aspects to make the patient smile. And finally, when she does, it's a beautiful smile that she has. And you can see that despite the severe atrophy, this concept of tilted and zygomatic, which is again a advanced tilted concept, works for such patients. You're giving a new life, a new chance for these patients to regain their confidence, the joy of eating when you can do these kind of procedures for these patients. Now, coming to another case where a lot of things were done. My patient, Mr. Batish, again, a very sweet patient. He wants to go ahead and make his implant.
Komal ma'am, we are not able to hear you.
Ma'am, network issues.
Am I live again?
Yes, ma'am.
Am I visible again?
Ma'am, we are facing network issues from your side. No.
There's 5 participants. I think it's fine. Am I seen now?
Yes, ma'am. Perfect.
Is it live now?
Yes, yes.
Okay. So I guess we were talking about this case where you can see that the patient had a history of failure of implants before, and the dentist who really restored this was not very sure whether he wants to go with axial or with tilted. So he went with small implants. So you have to understand here is that when you're going for tilted implants, you're going to engage the anterior maxilla and the anterior mandible, which are much more dense than your posterior maxilla and posterior mandible. You need to use longer implants. So in this case, I knew that I have got a defect here and I want to go ahead and place my zygomatic implant on one side. So in this case, we went ahead. The first step always, as I said, whether tilted or zygoma, you need to go for denture fabrication. And then here we made a stereolithographic model. We identified the anatomy. We did the mock surgery, created the channel, understood the path that we want to take, understood the length of the implant that we are possibly going to take. And then we did the markings on the patient's face again, go ahead, went to the incision. And now the plan is to go ahead and remove these implants, place my tilted implant. And now, first of all, what I'm doing is I'm identifying the lateral wall of the nose because I'm going to do a lateral lift so I can engage and use my bicortical stabilization of the flow of the nasal lateral nasal wall. I do my cristotomy. I separate the nasal mucosa. I do my nasal lifts here, do my osteotomy using my conventional implant protocol, then create a ramp, place my implant again. These are regular implants. In the anterior, because the atrophy is such that I don't want to place a shorter implant, I want to place a standard length implant. So I do my nasal lift, and then I go for the other side. Now in this case, I'm going to do my zygoma. So on the front, again, the axial implant placement using the nasal lift, using denture, understand high primary stability required, place my axial implants, and then go ahead and do the exact same thing for my zygomatic implant. For my zygomatic implant, so I mark the point of entry. I mark the point of entry on the zygoma. I join both the points together. I find out the direction. I don't want my implant to go ahead and go in the eye. I then go create a tunnel, and once the tunnel are made, I do my osteotomy, use my zygomatic implants, place my zygomatic implants. So in this case, if you can see, we have gone with a conventional tilted on one side, and we have gone for a zygoma on other side. Multi-node abutments to correct the angulation. Here, you have to use obviously not 35, but a little more, maybe 45 in this case. Place my healing collar. Now it becomes like a regular tilted implant case. So I make my impression, polish the surface. That's my provisional that has been created. Do my one screw test for the patient. That's a maximum intercuspation and the final smile of the patient. So you can see that this protocol can be followed for any of your cases. This is your post-op CBCT. Ensure that you have not created any damage to the patient for you. So that's the same day post-op for the patient and a happy patient. Now, let me show you my last case for today, and that is my zygomatic implants here. A patient who, if you can see the amount of atrophy, you can see the amount of tissue loss that has happened because of the loss of bone. The patient has been edentulous for a long period of time. You can see here, lower can be gone for a regular tilted implant protocol. Here we can see there is absolutely no bone that is placed here. We open up, and of course the markings on the patient again. We make the incisions. We expose the zygoma on one side first. Mark the point A, the point of entry in the zygoma, point of entry in the bone. Once they are marked, we make the tunnel with this diamond burrs, and we verify the direction. We are not ensuring that we do not harm the patient in any way. Once a tunnel is created, again, I lift up the Schneiderian membrane to minimize the trauma. Even if the membrane gets damaged, it's all right because it's going to repair. We're not doing any grafting here. So we go ahead, we determine the length using the depth probe. I go ahead with my final placement, separate the mucosa for the nasal lift again in this case. Once it is done, I also place one more implant right at the center. You can do this. Obviously, I'm going to do some contour augmentation, place my graft inside the nasal lifts, do my contour augmentation, place my membrane, stabilize it. That's the final placement with the multi-node abutments. Close it. And again, the same protocol, go ahead, immediately load these. In this case, I converted the denture. And once it is converted, same step. One screw test for passivity. Now, if you see, these access holes are not too palatal. The patient is going to be able to speak, not that as great as it is on the crest, but it is as close to the crest as it can be. Also, as I said, do not make your denture very, very weak. A very important aspect here. That's in maximum intercuspation. That's the final post-op OPG immediately to ensure that everything is perfect. Coronal sections showing the engagement of zygoma here. And that's how we started off. So you can see here the same day post-op, we have restored. We can see how we have been able to make a change in this patient. So coming to the tail end of my presentation, what are the take-home points for this entire discussion? Tilted implants should be considered only if axial implants are not possible. At the end, the skill of the operator and the technique matter much more than the costly implant systems, stents, and guides. You can use any system you want for your tilted implant protocol. The right thing is to have the correct information, the correct skill, and the technique. I find this a very, very important lesson in my life, and I would like to share this with you, is that if you are not willing to learn, no one can help you. And if you are determined to learn, No one can stop you. The work you're doing is actually your signature that you're leaving in your patient's mouth. Quality means doing it right even when no one is watching. And contrary to what people may tell you, it is a race. And the dentist who does the maximum implantations a given month, who delivers the more beautiful smile, and has the happier patients wins. Go for it. Thank you very much. So thank you, Dr. Jasmine, again for being patient, and thank you all of you for being so patient with me because of network issues. I knew that there's going to be some problem considering how people are facing network issues and the amount of time people are spending on Netflix. There has to be a limit of how much net is going to be provided to us, right?
Beautiful presentation with amazing cases, ma'am. What a wonderful session and more than 700 lives. It seems
Thank you.
everybody present here is appreciating you. And
Thank you so
ma'am,
much. I really, truly appreciate everybody's patience and thank you for joining me.
ma'am, there are so many questions are waiting ahead.
Yes,
So
so
first question is by Dr. Krishna. She asked, in case where upper natural dentition and lower all on 4 given, what will be the occlusion scheme?
you have to have mutually protected occlusion. Whenever you talk about occlusion in a full arch, what you need to see is what is the weaker arch. So in this case, now obviously I cannot discuss about the occlusion in this brief period of time, but you will have a mutually protected occlusal scheme if you have natural dentition on one and the opposing dentition is a tilted implant or implants. Not just tilted, even axial implants for that matter.
Next question is by Dr. Tirath. He asked, in case where root submergence was done, please explain that why roots were submerged.
So in that case, my patient Kamal Patil, that is what I think you're referring to. That case, we had to. The patient was diabetic. I had explained to you. So I kept those two teeth to give the patient a temporary. For the upper, I could not do anything, but the lowers, whenever I'm deciding on a full mouth case, I always, the first thing that should come to your mind, or not just mine, yours, is what kind of temporary are you giving the patient? As I already mentioned that I don't like giving the patient a denture. So if I can't place or load these implants immediately, I will keep some kind of teeth. So in this case, I kept those two teeth which were healthy, parodontally, nothing was wrong with them. So rather than extracting them, I submerged them so that the alveolus could be preserved in that area. This is mostly done in the anterior region in the pontic side, but even in a full mouth case, I have submerged those teeth so that the alveolus is preserved.
Okay. Next question is by Dr. Nishant. He asked, what will you prefer for rehabilitation of maxilla? Anterior implants with sinus lift plus implant or anterior implants with pterygoid implants?
Well, depends on, again, so you can't randomly talk about a treatment plan for a patient. As I said, that you have to look at the patient as a whole. You have to not, you can't decide on the treatment protocol looking at the x-ray and not decide on what you like to do. If I have a young patient, I would probably do a sinus lift cases. I would do sinus lift on both the sides. I will place tilted implant in the anterior, do my sinus lift, place simultaneously two straight or three straight implants, depending on the case, to get a good AP spread. Submerge those implants, come back after a few months, and then go ahead with my final prosthesis. If it is a 75-year-old male patient, female patient, who I do not want to go ahead and do so much because the patient's expectations, the patient's bite forces, everything is going to be different. The prosthesis for a 75-year-old is not going to last for more than 10 years, 15 years. For a 35-year-old male patient, the prosthesis is going to last much longer. So I need to plan that way. With regards to whether I would like to do sinus lifts or whether I would like to do pterygoids, now that becomes individual choice. I know a lot of clinicians who, for every case, go for pterygoid implants. For me, I do not prefer pterygoid implants because unlike zygomatic or unlike these tilted implants, it is a blind procedure. So for me, given a choice, I would rather go for sinus lifts because something which is more predictable, which I can see. But that's my take. If you are good at pterygoids, please go ahead and do pterygoids.
Great. Next question is asked by Dr. Paresh. He asked, when we give temporary removable reline denture, can we give it on a healing cap or compulsorily on a covered screw and sutured mucosa? What instruction to be given?
Okay, so if I have to give a denture to the patient, now, as I said that I would not prefer to give a denture. If I have to give a denture to the patient, I would not give a cover screw or not give a healing collar and then places, because you're ultimately loading the implant, because there is going to be loads on this and the implants. If I have to go ahead and give a denture, I will submerge them completely. I will also reline them with a soft liner. But please understand that for a soft liner to really work, to cushion the forces of occlusion on the implants, they have to be at least 4 millimeter thick. And if you make 4 millimeter thick soft liner, in that process, you're going to make the denture very weak. So it is a very catch-22 situation. And I would try anything, but or try to convince the patient not to wear those denture in that healing phase, or give temporary implants between my primary implants. But if I have to give a denture, this is the kind of thing that I would do. Not give the patient covers healing collars. Let it be submerged then completely.
Okay. Next question is by Dr. Abhilash. He asked, what is the difference in the approach if the opposite arch has natural teeth?
So as I said again, if the patient has natural dentition, means the forces are going to be higher. So you need to sometimes over-engineer. Again, depending on what is the age of the patient, what are the expectations of the patient. Some patients want teeth from second molar to second molar. When you're talking about tilted implant protocol, you're going for the with a shortened arch. So if the patient has natural dentition in the lower till the lower second molars, then obviously just going with tilted implants would not be sufficient. Then you would probably want to do a sinus lifts in case there is sinus pneumatization, and go ahead and place those implants. So the occlusal scheme, I'm sorry, the question was what would be my approach, right? Or
Yeah.
occlusal scheme. Yeah. So that depends.
Okay. Then Dr. Tirath asked to explain ramping.
So when you place your implants which are tilted, now they are not placed at one angle, they are placed at a angle. So here part of the implant, the mesial part of the implant is at the crest, and the distal part of the implant is submerged. And when I place my abutment over it, there is a lip of bone which is standing right there. So when I place my multi-unit abutments on the top, my multi-unit abutment might not get completely seated. So if you're keen to observe, if you are paying attention, if you saw my case, the first tilted implant where Mr. Shirsad I showed you, you saw that these abutments were not completely seated. If you were seeing it clearly, and that is because there was no ramp created. And that is an issue with a flapless procedure. So before you go ahead and place your implants, in short, what you do is after you've done your osteotomy, on the distal aspect of your osteotomy that you've created, you take a round burr and make a saucer-like defect so that you have space for the multi-unit abutments to get seated there. That's all.
Then Dr. Aman asked, what about fracture of temporary?
What about fracture of temporary? As I said, that the temporary has to be fabricated with a high strength acrylic. You can have metal reinforcement in that. You can go for intraoral welding and then make a temporary so that they do not fracture. I would suggest that if they fracture, I would suggest when you make an impression you have of that same patient after the surgery, do not throw away the cast. Let the cast be there with you for a while. Because if the patient does come back in the temporization phase, in that crucial 6 weeks, and if it is fractured, very, very carefully remove the temporary, place it on the cast, because making impressions at this stage would be very difficult. Go ahead and repair it and give the patient again back. So this, of course, has its own problems. Or just go ahead and remove the temporary and give the patient tell the patient that he has to wait. So depending on how you can manage the situation.
All right. Next question is by Dr. Aishwarya. She asked, in tilted implant cases, will you recommend immediate temporization or final prosthesis after 3-4 months? Which is the best option will you recommend?
See, understand that tilted implant protocol was designed to give immediate restoration to the patient. And given a choice, I would any day prefer giving the patient immediate temporary, waiting not just for 3 months, but maybe 6 months, 6 to 8 months before I can give the final prosthesis. That would be my choice of really working with the tilted implant concept.
Then Dr. Rastogi asked, can you explain more about the ramp in multi-unit abutment?
I think we already answered that.
And then Dr. Sagar asked, difference between active and passive.
Active, I think this is not in the the discussion, is more of a basic topic. But what I can tell you is that using an active implant in these cases would be great because you would require less drilling. Active implant will engage the bone with very, very minimal drilling. Passive implants will require a lot of drilling, and the chances are that you might lose your stability and you might not be able to load these implants. So these cases, I would love to go with active implants.
Then Dr. Amar asked, if there is an extension of the nerve to the mental foramen, how can we deal with it?
Sorry, what? Can you repeat the question?
If there is an extension of the nerve to the mental foramen, how can we deal with it?
Extension of the nerve to the mental foramen. I mean, you have to understand that there is a loop. When the inferior alveolar artery exits from the mental foramen, there is always a loop, and almost 80 to 90% of your patients will have that loop. A CBCT planning is required. The best way, if you're talking about how you understand that you do not damage the nerve, is by visual inspection. Raise a flap, see the mental foramen. The chances are that if you actually raise a proper flap, see the mental foramen, see the nerve coming out of it, you might not damage it. And keeping in mind the anterior loop, you will ensure that you are going ahead of it. And if the patient has paresthesia, obviously that is either with axial or tilted, you need to remove that implant. And the critical time in this is the first 24 hours, and you need to ensure that within the first 24 hours you're taking care of this. And if the patient complains of paresthesia, take out the implant so that there is no irreversible damage to the nerve.
All right. Then Dr. Sania, she asked, do tilted implants and axial implants perform equally?
Yes. Tilted implants, if you talk about tilted implants as a unit which is cross arch stabilized, then they perform equally. But if you take a single tilted and a single straight implant and see the same forces on them, the forces on a single tilted implant is going to be higher. The key really is joining all the implants together rigidly, cross arch.
And then Dr. Ricky asked, ma'am, are basal implants and tilted implants same?
No. And yes, in a way, because I do not do basal implants. Basal implants also are placed at an angle, so they technically become tilted implants. The implants that I use are the conventional implants, which are going at an angle, but the prosthetic component is taking care of that angle. The abutment is not attached to the implant itself, so the chances of the prosthesis retrievability, cleansability is higher when we are going with a conventional implant protocol.
Thank you for taking the time to speak to us today on the very important topic, ma'am. And thank you so much. And I feel women like you are inspiration for other women across countries.
Thank you so much.
It
And
was really a great session full of energy.
thank you so much. Okay.
Ma'am, at last, do you like to say some words?
Thank you for being so patient and enjoy this lockdown period. Look at it positively. All the things that we could not do. For me, I could not sleep. But nowadays, I can sleep the way I want. I can catch on the movies that I have missed. So look at it in a positive manner. Come back bigger and better.
Thank you, ma'am. So we'll be back with our next session in few minutes. For more information regarding certificate, registration, speaker schedule, visit www.gomha.org. Till then, stay tuned. Thank you.
Thank you. Bye-bye.
Bye, ma'am.